Welcome to Healthy Work Collaborative, addressing precarious work through social change. We're glad you're here. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating today's webinar. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing or to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You will be emailed the direct links for all of these items when they're available. As I mentioned, my name is Yusra, and I'll be moderating today's webinar and Q&A session. Our presenters are Dr. Christina Welter, Dr. Lauren Conroy, and Ms. Tessa Bonney. Dr. Christina Welter serves as Associate Director of the Doctorate in the Public Health Leadership Program at the University of Illinois at Chicago School of Public Health. Dr. Welter is also the Director of the Mid-America Center for Public Health Practice. At UIC, she helps to lead one of the nation's only doctoral programs in leadership and oversees several national and regional workforce development and practice-led research initiatives, including serving as the Center for Healthy Work Outreach Director. Dr. Welter is a committed health promotion practitioner and researcher. She facilitates academic and practice partnerships to understand and collectively build evidence to address public health challenges with innovative and achievable policy, systems, and environmental strategies. Dr. Welter's expertise is to facilitate systems-oriented change by partnering with others to design, execute, and evaluate strategic and asset-based improvement initiatives. Dr. Lauren Conroy is a professor of environmental and occupational health sciences at the University of Illinois at Chicago School of Public Health. Dr. Conroy receives her Bachelor in Science in Chemical Engineering and her Master's and Science degrees in Environmental Science and Physiology with a concentration in Industrial Hygiene. Dr. Conroy has more than 25 years of experience in research, curriculum development, and teaching in occupational and environmental health. Her expertise is in the evaluation and control of hazards in the workplace and community, work that has involved substantial field work requiring outreach to employers, unions, and community-based organizations. Dr. Conroy led the Illinois Occupational and Environmental Health and Safety Educational and Research Center for more than 15 years and serves as the director for the Occupational Safety Program. She is the director of the University of Illinois at Chicago Center for Healthy Work and serves as co-director of the Greater Lawndale Healthy Work Project. Ms. Tessa Bonney is a doctoral candidate at the University of Illinois at Chicago School of Public Health in the Environmental and Occupational Health Science Division. Ms. Bonney received her Bachelor of Science in Biological Sciences and her MPH in Health Policy and Administration. Ms. Bonney is a research assistant at the UIC Center for Healthy Work and at the Mid-America Center for Public Health Practice at UIC. And now, I will hand it over to Dr. Welter.
Thank you so much, and we really appreciate the opportunity to present to you all on our Healthy Work Collaborative, addressing precarious work through social change. I just wanted to do a little overview of what it is we're going to be talking about today. So this is our agenda. We are going to be spending some time introducing and discussing what is precarious work and what is its history, particularly in the United States. We'll talk a little bit about our Center for Healthy Work, and then in particular, our research projects that help to facilitate the creation, and we'll discuss the Healthy Work Collaborative and early evaluation results, and then we'll open it up for some questions. Our learning objectives today cover what some of the items I just discussed, but we're hoping that you can have a sense of the history around trends to employment, including the current state of employment in the United States, understand what precarious work is, including some of its root causes, and facilitators and barriers to healthy work. We will discuss what policy systems and environmental changes, which is our approach in creating the Healthy Work Collaborative as a way to address systemic and structural change. We'll talk about the importance of multi-sectoral work, which is what the Healthy Work Collaborative fosters. We'll talk a little bit about how powers and levers of change are important skills for public health and healthcare organizations to effectively address health equity. And then share some of our findings that may lead to promising practices for PSC approaches to address precarious work, and we'll share some lessons learned so far. So first, we just want to get a sense of who is in the virtual room with us, since we aren't able to see your faces and hear your voices. So if you can please answer this question: what is your role at your organization? Are you a clinical care provider, a health educator, a wellness manager, coordinator, an HR manager, executive or director, researcher or academic, or other? If you could answer this poll question, and if it's an other, please type in the answer. Just give you a few minutes.
Yeah.
Oh, go ahead.
So we have 6% of clinical care provider, 3% of health educators and or wellness coordinators, 56% of human resources, and 3% of executive or directors, and 33% of researchers or academics.
And are there any others?
1% of others.
Wonderful. Well, welcome everyone. We're glad to be on the webinar with you. So as we present the information we're going to be sharing today, we wanted you to ground yourself in lived experience. And imagine this scenario that I'll read to you now, and think about, as you read this scenario, think about workers, people that you work with, people that you know about, and what it might be like to be in a precarious work situation, or if you're in an institution and as you start to realize perhaps your own institution might be undertaking some aspects of precarious work. So consider this scenario. You are a human resource manager at a large health institution. Many employees in your institution are low-wage hourly workers like janitorial or cafeteria staff. You have noticed that many of these workers have to work a second job in order to make ends meet, leaving them less time to make healthy decisions. What would you do? Why should you be involved or not? And what are your barriers and opportunities? So if you can think about this scenario as we present the information today, it helps us to realize what it feels to be a worker in this situation.
Okay, so I'm going to take over for a few minutes and talk about precarious employment and total worker health. So first I'm going to start with definition of a few terms. I think many of us are familiar with standard employment arrangements. These are jobs where you have a full-time job with a single employer. You have a predictable work week. It's generally at your employer's place of business, and there's some expectation of a long-term career development and an unambiguous work relationship. You know who you work for. There's a legally established employer and employee relationship. But what we're seeing is an increase in non-standard or alternative employment arrangements, and there's a lot of different terms that are used for this. I'm going to define a couple based on how we're using them and how others have defined these, but often they're used interchangeably. But independent contractor is in the United States, a defined term by our Internal Revenue Service, and it has to do with how people pay their taxes. And this is a specific definition where the payer has the right to control only the results of the work. So they don't control what will be done or how many hours or any of that. And this is really a business relationship rather than an employment relationship. What we've seen in the United States, though, is in an effort to reduce costs that many employers have been misclassifying workers as independent contractors and that don't meet this definition. And there have been some efforts to address misclassification. But we also have a number of other types of alternative work. And so the gig economy is one where it doesn't currently employ a lot of people, but it is becoming a more noticeable segment of the economy, and these are generally app-based, and mostly these workers are classified as independent contractors. And then there are two other groups that I'm going to define, but contingent work is where there's no expectation that the work will continue regardless of performance. And contingent work is at all levels of society, both at all wage levels and skill levels. There's examples of contingent work. And then there are alternative work arrangements that are include contingent work, but also can include on-call and part-time employees, people that are hired through temporary agencies, and independent contractors. So what we've seen over the last several decades is a shift from standard work arrangements to more and more workers being engaged in alternative work arrangements. So in the 1980s and earlier, we saw that many people had more standard employment and there was higher participation in labor unions. But during the 1980s and 1990s, we saw a shift where businesses outsourced factory work. There was a decline in unionized service and other blue-collar jobs that had benefits, and there was a contracting out of many positions or whole units, such as landscaping or janitorial services. Over this same time period, there was also a concerted effort and political action to deregulate workplace safety. So what we see today is a rise in non-standard employment, and about 1/3 of workers are low-wage earners, and 40% of those are in contingent work arrangements. So why is this important? So we use the term precarious work and have a working definition that is characterized as insecure, unstable, or uncertain, but also lacking flexibility, having no control over hours or schedules, having limited social benefits, little opportunity for advancement, and generally low wages and economic uncertainty. These jobs also often have exposure to dangerous and hazardous conditions and little protection against discrimination and exploitation. The consequences of this is that many workers with precarious jobs really can't take care of their family, they can't pay off debts, pay for education, save for retirement, buy health insurance, or pay medical costs. They're also more likely to keep working when they're sick and to be injured on the job. They also are more likely to be dependent on one or more social safety net programs. Recently, investigators in Spain proposed a conceptual model linking non-standard employment arrangements and specifically precarious employment to conditions that and adverse health outcomes. I'm sorry, and they use the term precarious employment and have looked at the a relationship between government policies and upstream factors in the economy and poor health outcomes downstream. And their work highlights that workers in precarious employment reported experiencing worse working conditions, receiving less occupational safety and health training and information about their work environment, and having less access to safety equipment. These same workers were also at a higher risk of suffering occupational injuries. We also see other health outcomes for low-wage workers. They have more risk behaviors than higher-wage workers. They are less likely to engage in screening activities, more likely to have to experience physical inactivity, and to be have higher rates of smoking in this group. So the implications for the individual are pretty clear in that workers are more likely to be injured and suffer from adverse health outcomes, including many chronic diseases. But the impact for society is also significant. A study in the Journal of Occupational and Environmental Medicine looked at the economic impact of low-wage work and worker health. And they translated their findings on chronic disease and risk behaviors into productivity costs, and found that compared with workers earning household incomes of $75,000 or more, again in US dollars, those earning less than $15,000 reported an average of 1.6 excess poor health days in the past 30 days, so more than one day a month. This translates to a cost of about $400 per worker, or about $2.1 billion for the lowest wage group in the United States, which is about 5.3 million workers. Okay. So we're going to ask another poll question to find out how many of you have heard of total worker health.
Okay, and it looks like there's 45% of our audience that has heard about total worker health, 47 haven't, and 8% are not sure.
Okay, thank you. So we'll describe total worker health a little bit. So in the this is a program that was initiated by the National Institute for Occupational Safety and Health, and it's really a philosophy that's looking at policies, programs, and practices that integrate protection from work-related safety and health hazards, which is the traditional occupational health activities, with promotion of injury and illness prevention efforts to advance overall worker well-being. And it advocates for a holistic understanding of the factors that contribute to worker well-being, addressing working conditions that are detrimental to health before developing interventions that are really focused on behavior. So it's an approach to move upstream and look at the total workplace and all of the other factors that impact workers' health. So we are at the University of Illinois, the Center for Healthy Work. We are one of 6 centers of excellence in the United States focused on total worker health. And our focus is specifically addressing health issues and working conditions of precariously employed workers with a goal of turning unhealthy work into healthy work. We think of interventions often as some kind of individual behavior change, but in this case, taking this approach of looking more upstream, we've really focused much more on the context and the situations that workers face, and less on the specific behavior. We have 2 projects within our center. One is the Greater Lawndale Healthy Work, which is really working at the community level in 2 high hardship communities in Chicago to really look at, to understand and then to also address the impact of precarious work at the community level. So engaging with community organizations and community members to change the nature of work in these communities and to improve worker health. In many cases, we've taken this approach because these workers are not in standard work arrangements and are not really reachable through traditional workplace or employer-based programs. So we've moved to a community-based process. Our other project is the Healthy Communities Through Healthy Work, which you're going to hear quite a lot about, one of the initiatives of that project following my presentation. But this project is really looking at a systems level approach, trying to change the systems and policies and practices around work and health in the city, but also looking statewide and nationally.
Thanks, Dr. Conroy. This is Christina Welter again. So I, with some of the colleagues in the room and others that are not here today, we lead the Healthy Communities Through Healthy Work project in our Center for Healthy Work. And we have 3 goals in mind for our project. The first was to assess perceptions of precarious work versus healthy work in system-level partners. And when I say systems level, I really mean cross-level and multi-sectoral. Looking at, as Dr. Conroy said, national, state, regional, and local. I don't mean hyper-local. We stayed at a more of a community level or sort of a regional community level. We're a large jurisdiction here in Chicagoland. The second thing we did is look for, identify, and to understand what initiatives, interventions is another word, are already underway to promote healthy work for all workers. And then based on some of those findings, to expose the opportunities or the gaps where we could build on the assets of our partners that were already underway to promote healthy work for all workers in a sustainable way. And in a sustainable way, we use policy systems and environmental change to create these structural changes that are known, evidence shows, to be more sustainable. And just to talk a little bit more about policy systems and environmental change, which is one of our core approaches, there's quite a bit of research here in the United States and internationally talking about the more profound population level impact that I'll refer to it as PSE change, policy systems and environmental change, can have. That individual behavior change programs often do focus on, for example, the individual worker, smoking cessation programs, dietary change programs, really different physical activity type programs might help to raise consciousness and awareness of an individual worker in a typical work setting or a typical organization. But as you just heard, precarious work is anything but typical. It's very complex. Workers don't typically have an organization that they're regularly working through. Their work hours are irregular. They're unlikely to have benefits. So being able to undertake individual behavior change is unlikely to be effective. Or even really reasonable. And the reality is that precarious work is in part caused by multiple factors in the larger system that have to do with an imbalance and unfair distribution of resources. And so what we want to do is to intervene at that systems level and start to change behaviors at that level so that it becomes easier for everybody to live, work, pray, and live and eat in a healthier way. And so even though when we think about some of these changes that it might be what we call PSE changes, policy systems and environmental change, a very common one here in the U.S. is to work on increasing access for healthy fruits and vegetables. So in the United States, we will make efforts to make vending machines have access to fresh fruit and vegetables. And so if you introduce this healthy vending machine, we have here one in our school that produces fresh salads. You know, that'll increase our fruit and vegetable consumption, and then it'll reduce our risk of diabetes and obesity. The problem becomes in the case of a worker who is low wage or in a precarious work situation, this is not something that is sustainable. It doesn't help address the root causes of precarious work. And you can see all these questions that have just popped up on the screen in terms of why this particular method in an organizational setting. Not that it's a bad approach, it's not, we're not saying not to do this, but in terms of addressing or solving or improving some kind of positive change to healthy work isn't necessarily the best fit. So the rationale for our approach in what we call the outreach core of our Center for Healthy Work is just what I said. That precarious work is a complex problem. It's different than in other types of typical worker safety, health and safety interventions, that we don't have one organization, that there are many root causes to precarious work. And so therefore, the design of our research and our interventions, or we like to call them initiatives, needs to be different. Our approaches and our thinking need to be different. There's not going to be there's not going to be one intervention or one program. It's going to be multiple interventions or multiple initiatives operating at higher levels and multiple levels with multiple people. And so what you can see on the right-hand side here, for those of you that aren't familiar with total worker health, this is a publication that came out in 2016 trying to argue for what needs to happen to produce total worker health. And we've added at the top of this reform, that the total worker health model is typically very organizationally based, sitting within a workplace. We do not. Our center really looks at the community and systems level, and we're calling for the reform of norms change, of policy change at a non-organizational level, ideally, and systems change. And so what we've chosen to do is undertake an action research approach. And just a little bit about action research. There are different frameworks that different folks use around action research, but One model produced by Springer suggests that there are 3 steps. The first is to plan for what it is you want to do. Then you implement once you've understood the scenario, the situation you're working with, and then you evaluate. So simply put, on this plan phase, what we're going to share with you today is that we undertook it in the first phase of the plan stage. We undertook a systematic inquiry, and I'm going to share the look results, which is phase 2, the analysis and interpretation of that systematic inquiry that helps then lead to the ACT, which is our Healthy Work Collaborative. And here's just another diagram about this under this plan phase, which is where we are right now. In the phase 1, which was the systematic inquiry that we undertook, we did a literature review. We undertook 55 key informant stakeholders interviews, and we developed an intervention database, as I alluded to, of what was already underway. We did data analysis with partners and our team, and then we developed the Healthy Work Collaborative. So just said a little bit differently, I want to say a little bit more about our data. So we conducted 55 key informant stakeholder interviews with a variety of multi-sectoral folks that included governmental public health, healthcare entities, social service agencies, worker centers, worker advocacy groups, unions, educational institutions, and a few others to try to get a diverse sense of what overarching themes around precarious work as well as initiatives existed. And we purposefully did this in a very diverse way to see what the common themes were around precarious work and capacity building. We then, over several months' time, and analyzed this data to look for 2 things. What were the perceptions of healthy work and precarious work among these diverse stakeholders? And then what were they doing that seemed to be working or not working to address the issue? Based on our findings, we conducted what we call readiness interviews with about 15 of these organizations to test and see if the thinking that emerged made sense and some of the things we were thinking about to address some of the gaps and opportunities made sense. A quick summary of our findings, and hopefully this can begin to tell the story of why we developed the Healthy Work Collaborative, are those that are on the screen. That we found that activities to address precarious work were done in silos. There are few organizations working together across sectors, and by sector I mean a worker center working with a public health organization. That was very rare, at least in this particular sample. This isn't, generalizable or representative necessarily. It was purposeful, but it was a small sample. And they were not working across levels, meaning if you were working at the community level, you weren't working with a statewide organization and therefore less likely to create systems change. There was a varying degree of knowledge or consciousness around how to address precarious work or what it was and what the factors were and the pathways were to create healthy work. There was an opportunity, particularly we found for the public health, governmental public health and healthcare sector, to reframe their thinking at a population health level. So public health often does these individual change approaches like the vending machine, and they weren't really sure, while they were interested in, but they weren't really sure how to address precarious work. They didn't know what the strategies might be. In our intervention database, really interesting, again, not generalizable and not representative, but very interesting purposeful findings, sample findings. Over 70% of the initiatives that we found were what we call health-directed, which means addressed a health issue, came from the health sector, whereas 88% of the initiatives that were called health-related, which addresses things like wage, came from other sectors. And so what you can see is that the health field is not addressing root causes of precarious work, and the other sectors like labor and advocacy, no surprise, are addressing issues of low-wage work. So you can see a natural potential alliance there. While only 15% of the initiatives shared by the health sector were policy-related, twice as many, 28% of those shared by partners outside the health sector were. So again, an opportunity to put together the health sector with the non-health sector. And finally, 41% of the health sector's initiatives were defined as programs or internal business policies, while only 27% of the non-health sector's efforts focused on this time and locate at this, in that way at the location-bound initiative. So in other words, the public health and healthcare were more likely to be working at the organizational level, not the systems level. So all this led us to an opportunity that we tested with our partners first. We wanted to make sure they were interested, they were ready, they wanted to come together. To put together, we put out an application to participate in the Healthy Work Collaborative. And the Healthy Work Collaborative was a group of about 30 folks, 8 teams in total, in which folks applied to come together with public health and healthcare organizations coming to work with labor advocacy and worker centers. And our goal was to build the capacity of public health and healthcare to better understand and then take policy systems and environmental change action on precarious work. And we, based on the results in the literature from our first action research phase, we wanted to connect people together to learn from one another, particularly for public health, to learn from the worker advocacy folks. We wanted to give them additional tools and training around PSD change in this field, and then lead the collaborative with a work plan to be able to actually employ some of those findings, some of those learnings. So the key themes, components, and there's a lot more here that I don't have time to share in terms of the theoretical underpinnings for the collaborative, but was to have a focus on precarious work, to help the participants change strategies that are cross-sectoral and multi-level, which is a gap in the findings that we found from the findings, that uses action learning to reflect in practice as to what's working and what's not, and to build relationships between public health and worker centers and worker advocacy groups. And we had 3 major components. This Healthy Work Collaborative was done in the summer of 2018, and it launched in May and ended in July. There were 6 sessions that were approximately 4 hours each, where everyone came together in person, although you could do some of this online, not all of it, but some of it. And the sessions were, again, there were 6, but they were clustered in 2 sessions to understand the problem, to understand the systems, strategies, and approaches to addressing that problem, and to end with a theory of change. How might you address precarious work in your community or in your system, and to develop a work plan. Another thing that we did that's important is we used worker centers to actually present at each of these sessions. It wasn't us as academics. We don't see ourselves as the experts in PSD change around this topic. Some of us are, but not all of us. And really, it's the worker centers and the unions and the labor worker advocacy groups that are the ones that know how to do the organizing and the systems change. So they served as technical assistance providers. We as the university took a slightly different role as facilitators of each of these 8 teams. And then the teams were multi-sectoral, as I mentioned. So just a quick sample of one of the sessions that had to do with what is doing a power analysis to understand who in our system or who in the participant system actually has the power to make decisions and actually make changes around a particular focal point or decision point in a system. And so we had one of our worker centers from the Restaurant Opportunity Center present and do a workshop with everyone to do a power analysis grid and really have a debate and discussion around what is power, who has power, how does it play out in making policy change and in systems change, and then thinking about stakeholders, who should you be working with or targeting to try to shift the power to be able to provide workers more rights, equal access to affordable, to reasonable jobs with a living wage, and so forth. And we had very active sessions. The next session that we had that was similar to understanding power structures and what it really feels like. Again, we really emphasized many of us are fortunate not to have to work in a setting that is like precarious work. So you can't see this terribly well, but one of the worker centers did an exercise dividing most of the group into two sections. One section was to represent the workers who had very little power, and the other was to represent the equivalent of a couple of people in power. And they had to play soccer together, or football if you're not from the United States, where the few had most of the power and were given all the easy rules and all the easy instructions, and the many did not. And of course, those with the few won the game. And so they had to come up with a theory of change. What approach could the workers use to overcome those in power? And I just want to give you 3 examples, and before I turn it over to the results of the evaluation results for our collaborative, what came out of this process. Because we did do pre and post tests and key informant interviews that we'll show the results from, but these are some of the concrete projects. So one team was a national public health advocacy nonprofit that has local chapters all over the U.S. They identified that their workers, both locally as well as nationally, had a poor understanding of precarious work. And so what they decided to do as a part of our collaborative is to develop a curriculum specific to their organization that would instruct their workers about how precarious work was a social determinant of health, how they might begin as they work with their partners, who are often other organizations, to start talking about how they could address the barriers and opportunities. And what they're doing is to develop a train-the-trainer within their organization. The next team was a public health policy research group with statewide scope here in Illinois. And so they developed an internal equity committee to evaluate how their workers, and in particular their interns, were referred to their organization as well as paid in their organization. And so what they're doing is developing a paid internship program and really examining the power, favored power referrals that are happening for people to get internships. Often people get internships in many organizations by who you know, versus it being an equitable application process. So this actually has huge implications nationally eventually in terms of really opening up the internship field in public health. The last example, it was a partnership between a large hospital system, a legal aid group, and a worker center. They identified that the workers coming through their organization were unaware or not as aware as they could be of their worker rights, discrimination, and wage theft and wage hour requirements. So they're working on developing a referral system as patients come into the healthcare system to a legal counsel who can educate them, help them make sure that their workplace rights are being met and not being violated, and helping them file for worker compensation. And so this is also a staff training, but also a systemic change with this referral system, which again ultimately has this implications system-wide to help with other employers. And I'm going to turn it over to Tessa, who's going to share some of our evaluation results.
So we have some preliminary evaluation findings from the Healthy Work Collaborative meetings that happened this summer, and some evaluation of what groups have done since those meetings. Prior to the first meeting, we conducted pre-evaluation a survey with the participants to gauge their baseline understanding of precarious work, what they were thinking of doing as a project or a specific area of interest, and why they were coming to the Healthy Work Collaborative, and to better understand which of the other participants or technical assistance providers from the worker centers and other labor advocacy groups they were already working with or knew in any capacity. We collected similar information in the post-collaborative evaluation survey, and then we did 3 rounds of post-session reflections after each of the bucketed sections that Christina mentioned. So for the first 2 sessions, the understanding of the problem, we found an improved understanding of healthy work and precarious work and the relationships between work and health. For system strategies and approaches, the second bucket, participants indicated that they had improved critical thinking skills around their projects and what they might do in their own organizations to address precarious work, and a better understanding of the power dynamics and who they might work with to address problems. The power analysis in particular came out as being important for organizations as they might not typically consider power, especially in the health system or public health system when deciding what to do as an intervention. And then finally, the theory of change helped people really improve their strategic planning skills. So given everything that they had learned in the sessions, what might they do going forward and who might they partner with? As I mentioned, some of the tools in particular were perceived as being particularly useful, both during the sessions and since the conclusion of those sessions. So we are in the process of conducting roughly 60-minute evaluation interviews where participants are sharing much more about what they learned from the process and what they've used since the conclusion of the 6 meetings. And power mapping and theory of change were 2 particularly relevant tools that participants use. Since the collaborative 6 meetings, organizations have worked or begun work in a different capacity with some of the organizations that they were not already familiar with. So as you can see here, pre-collaborative, in the gray segment of the circle, many organizations had really no existing relationships. And this was primarily these health organizations hadn't worked with the worker centers or hadn't even met someone who worked at a worker center prior to the 6 meeting process. And at the conclusion of the process, this dynamic changed, and many organizations reported at least a networking relationship with other participants who were there. And this went both ways. The worker centers also expressed that they had made new connections with health organizations that they were interested in partnering with in the future. So moving forward, since the 6 meetings concluded, as we mentioned, some groups came in with a specific problem or area of focus that they hoped to address. We're now moving into this implementation phase in which participant groups are going to take action on their projects. And at the conclusion of our 6 meetings, we collected some feedback from participants as to what they might need to move that work forward, what supports they might need from us as a university, and who they might need to work with to make their vision a reality. And so we're moving into this healthy work collaborative phase 2. So in summary, what we learned from the 6 meeting process was that these new partnerships were particularly useful to many organizations, and that some of the technical assistance from the worker centers and also from us at the university helped to support teams as they figured out what to do next and how to move forward. And the 6 meetings provided space and place for collaboration and learning that groups otherwise wouldn't have had. Many of these projects were new and are not central to the work that organizations had been doing, but the 6 meetings provided a separate space and defined time to move some of that work forward. And going forward, the goal is to facilitate these partnerships as they continue to deepen and provide an opportunity for organizations to continue exchange of knowledge and implementation of what strategies they've learned in the 6 meetings in this implementation phase. So the Healthy Work Collaborative Phase 2, the goal is to support participants as they move forward in their particular areas of interest, and to support the networks and the relationships begun during the 6 meetings over the summer. And the vision for this is that workers will really be at the center of the movement and decision-making to achieve equitable treatment and opportunity for healthy work in all of these systems and organizations who are present in the 6 meetings. And as a university, we are hoping to provide, some support for this ongoing work, both, providing time and space to move work forward, but also some small funds to support this work that might not otherwise occur. And so just to give an overall look at the Healthy Work Collaborative Phases 1 and 2 are what we've described today, Phase 2 being this implementation phase with the small funds to move specific projects forward. But Phase 3 would be continued support as groups implement and really institutionalize some of these projects within their own organization so that they become, core to the work that the organizations are doing, and so that these new partnerships between labor and health sectors are more sustainable and stick around for the long term. And then here are just a few lessons learned. That traditional outreach and dissemination approaches are not necessarily useful when addressing complex issues, and more time and space is really necessary to understand issues like precarious work and to develop strategies to address those. So we have a few discussion questions in the last few minutes that we have. We're interested in what was most surprising about what you learned today and what other questions you might have for us.
So to our audience, if you have any comments about the most surprising topics you've learned today, please enter them in the question box, and I'll just start our Q&A session. So the first question, our audience was wondering, how long does it take to make a healthy decision?
I'm not sure I understand the question completely. I think that we make, any individual in the course of a day make probably hundreds of healthy or unhealthy decisions, some of which take very little time, particularly around habits like putting on your seatbelt, and others, like what to cook for dinner, might take a little bit longer. And then these bigger issues around work often will take a long time. You might have to get more skills or whatever before you can even contemplate changing your job, say, or thinking about how you might move into a better position.
And I think just to add to that, what we presented today and what's happening here in the United States is that, and we found in some of our research as well, is that if you're sitting at that precarious work sector, not just low wage, but really precarious work, as you try to make these changes from sector to sector, if you're in one sector and you want to, like a restaurant sector, and you want to move to a domestic worker sector, it doesn't get better. So it really can be a never-ending cyclical, vicious positive feedback cycle, where unless you're able to get additional education or these businesses change their policies, which is what we're really after, you're going to be stuck in that cycle.
Right, and then there are some long-term initiatives that labor has been advocating for that we're seeing some movement towards in terms of minimum wage changes and paid sick leave benefits and other things like that, but those are long, multi-year initiatives around organizing and political action.
Thank you for that. Next question was, in your opinion, what interventions are the most successful, or which policies are the most effective?
I assume the question is geared toward the topic that we're discussing in terms of precarious work. What we can share is that there's early research underway right now on some of these interventions. For example, one which is called the co-production of enforcement, where in health departments here in the United States, there are restaurant inspectors who are able to go into an organization and have the authority to look for different violations for food and safety, but they are able to partner with some of their worker centers if they've heard there's also a wage theft violation. And there's some early, and so they've been partnering with co-enforcement and to be able to then talk to that, work with that restaurant and cite them for that wage theft. And there's some early evidence suggesting that that's effective. There's growing evidence in terms of minimum wage, increases in minimum wage and paid sick leave in terms of health outcomes and quality of life. There was I'll let Dr. Conroy talk about maybe the study that was just completed on the year-long results of Chicago and Cook County enforcing. They just enforced a paid sick leave and increase in minimum wage here in Chicago. And there were some early positive outcomes of that. So there's a lot of formative research being done right now on this topic. So I don't think we can point to one thing that's perfect or best yet, which is why we have this Center for Healthy Work.
Right, so a lot of our mission is to really examine and test some interventions that would change the context of work, not just a specific exposure or a specific situation, but really changing some of the power dynamics and also, increasing the stability and ability to support a family with work.
Thank you for that. Another question was, well, this was more of a comment. So healthy collaborative, healthy work is a great approach, and a lot of people would be interested in developing a similar program in our region. So the question was, have you published this method yet?
We're working on that right now. Thank you.
Another question is, could you give some examples of specific strategies that you suggested to collaborative members?
So I think we talked about 3 team examples in the presentation. Another team is working on what Christina was just speaking about, the co-production of enforcement locally here in Chicago. We have other teams looking at the use of community health workers statewide. We have another team looking at how to work with hospital workers who are not under a collective bargaining agreement or in a union, and how to organize those workers to identify issues that they are experiencing in the workplace, and then how to act upon them. I think that's a pretty good summary. You can add more.
Yeah, the one more, which actually has 2 projects because of the size of the jurisdiction. So for those of you that don't know, outside of the city of Chicago is suburban Cook County, and they were a part of this, the passage of an increase in minimum wage over the next several years, as well as the requirement of paid sick leave. So first of all, that's an intervention unto itself, and I'm not familiar with your jurisdiction. If in sort of typically Canada has more progressive policies than we do, but to take a look just at those policies, if there's paid sick leave as well for everyone, as well as the minimum wage increases. But there, because of that passage, not all of the municipalities adopted the, even though they were supposed to, not all of them adopted those policies in their local jurisdictions. They have 125 unique jurisdictions. So there are 2 projects trying to organize in some of those communities to enforce, raise consciousness and raise interest to encourage the businesses and the municipalities to actually move forward with the minimum wage and the paid sick leave. So it's a kind of a really generating a movement and changing people's social norms around what is an acceptable minimum wage, and that it's acceptable for paid sick leave, which I probably sounds a little silly because we're part of public health and this should be a given, but it's unfortunately not. So we're partnering with worker centers in their organizing strategies with the data and some of the health promotion techniques that health departments use. They're coming together to organize these 2.5 million people in suburban Cook.
Next question was, how long would you say it took you to complete the planning phase, as well as building the connections with various centers, such as worker centers, advocacy groups, etc.?
So I can answer the first, I think, or the second part of that. Because we've had a long-standing occupational health program at the University of Illinois, we had quite a few relationships, not necessarily partnerships, but relationships with a number of these organizations already, which we used as the starting point to start the collaborative. And then I'll let Christina answer how long the planning phase was.
And then I'm also a former public health deputy director, so similarly had a lot of relationships in the health sector. So it is ideal if you don't have those relationships, find somebody who does to help you get entree into those networks. And then it took us we were a brand new center, so there was a year or so of getting us up and running, maybe 6 to 8 months of just to get to the point of the first interview. However, because we have that lessons learned, we could, once we do publish our work, hopefully you could advance that much faster because we already did the thinking for you. And then it took us, another 6 to 8 months to analyze that and really get to the place of the Healthy Work Collaborative. So our center started in the fall of 2016, and the Healthy Work Collaborative launched in May of 2018. So that's approximately 18 months, again, acknowledging we were brand new and just getting up and started. And we're happy to share. We're working on writing up everything that we're doing. So the goal is to replicate it, to have a curriculum that others can use for the Healthy Work Collaborative, as well as the process we used that I think is really formative and important for readiness building to get to the collaborative to work. That was a key step before the collaborative could launch. Your collaborative might look different than ours did. It has to do with your jurisdiction, the assets, and the opportunities in your area.
Thank you for that, and I applaud the great work. Next question was, do you have an idea about costs associated with endeavors and plans for sustainability?
So in some cases, we're providing some initial seed funding for people to launch these, but I think part of the collaborative was really to explore and plan for a sustainable intervention that once it was seeded and funded would sustain itself. So there was a lot of, I think, discussion of what would work or what could work in these organizations, which is why all of the initiatives look so different, because it really was building on what was already happening in these organizations and how they could move forward. So I think the seed funding that we're doing is in the, $5,000 to $10,000 per initiative, not in the $1 million initiative. But again, it's sort of reinforcing what organizations might be ready to do already.
And I think there's also the goal that with this initial, 8 months of seed funding, that organizations at the end of, this mini grant period would be in a place where they have enough background work done to apply for another grant that would help sustain the work, that would not be, funded through us, but funded through an outside, funding agency.
And I just wanted to add that, this is Christina, that we are a funded NIOSH center for Healthy Work, so we have resources as a center that come to us, and then we've done the best we can to then redistribute some of those for these, what we're calling mini grants. And what everyone said is correct. We're trying to provide what we can while at the same time use an asset-based approach so that it isn't reliant on grants, because we have found in our experience the distribution of grant funds that really wholly support a project almost always end up ending when the grant funding ends. And so we're trying not to create that feedback cycle.
Thank you, Dr. Welter. What are some of the first steps of introducing or educating the concepts of the negative impact of precarious work to a broader community?
So I think that, again, there's been this systems approach that we talked about today, which is to some extent just asking people questions about what they know, and doing these interviews really did raise some consciousness. The Greater Lawndale project, which we haven't talked about so much, is just now entering an intervention or action phase of its project, and is just now exploring that question, like, how do we get people in this community? And these are two communities with high levels of, or high percentage of people that are engaged in precarious work, but to both recognize it, but also to change the norm. It's become sort of normalized. This is the work that's available to these communities or community members, and it's somewhat normalized. So we're really strategizing now about how we can change that conversation so that even if people still have these jobs, that there is some understanding that this shouldn't be normal.
I will just say I have used this environmental scan approach that we used for this project in both practice projects and research projects, some of the time with them resulting in long-lasting collaboratives. And to me, the first step is relationship building and asset mapping. And there are a variety of ways to do that, but really understanding who's doing what and what's working, and checking for the readiness to come together and have dialogue. And it's really through that inquiry, almost kind of an appreciative inquiry, that you start, most people become interested in wanting to begin to work together. And then the wish is that you come up with a shared vision of some kind, and you go from there. Doesn't always work. There isn't always interest. There isn't always a shared vision. But the first step is really whether you do it in a research method or you do it in a practice, sort of informal dialogue method. So you start where people are at and you listen.
One last question, and then I believe we'll answer the rest of the questions through emails. So the last question would be, have you faced any challenges with your funder and or community partners retaking a systems approach that might be considered more political, example, promoting labor organizing, because getting funding is a bit challenging?
We have not faced opposition from our funder, and we are somewhat unique in that we are taking this very worker-centered, as opposed to employer-based approach to this. That's not completely fair. There are other centers that are also very worker-centered, but we really feel like the drivers of this are bigger economic and political factors. So really, to make a dent in changing precarious employment is going to take changes to our political and economic structures. As a federally funded grant, we have restrictions on what kinds of political action we can engage in. But most of what we have been doing is really giving skills around advocacy and connecting people together. And we haven't been directly, say, lobbying for things. So we haven't faced any pushback. And from the community partner side, I don't think we have faced much in that side. I think they welcome this, as Tessa ended with, this opportunity to have a space and time that we've facilitated to try to make this possible for them to work together.
Thank you, Dr. Walter, Dr. Conroy, and Ms. Bonnie for this compelling presentation. We had a couple of comments about the most surprising items that our audience have learned during this webinar, if you'd like to share them.
Yeah, so the first comment we got was that it was surprising that health-oriented agencies were open to discussing power dynamics and partnering with worker centers to learn from them. Additional comments were that the most surprising aspect is simply the amount of significant work being done to address this growing phenomenon.
Did you have any other messages to our audience?
No, I don't think so. I think on the screen now you see how to access some of our information, our website, and how to contact us if you're looking for more information.
Yeah, for sure. And we'll share the recording and the slides with our audience as well. Thank you all for joining us, Dr. Walter, Dr. Conroy, Ms. Bonnie, and thank you, Elizabeth Fisher, for playing a major role in coordinating this webinar. Thank you so much to our audience for joining us.